Ladies and gentlemen, thank you for your interest in this topic. The prevalence of diabetes mellitus is increasing rapidly in virtually all parts of the world as type 2 diabetes is showing up in young adults and even teenagers. The consequences of that will dramatically elevate the need for us to care more efficiently and effectively with foot wounds. We will need to improve our ability to prevent, heal, and avoid recurrence. We intend to summarize the background science, the clinical, and the technical aspects of a therapeutic technology which promises a distinct leap forward. For decades, we have sought the optimum combination of materials and techniques to reduce pressure levels on at-risk areas of the foot. That approach has certainly been helpful, but there is another opportunity to protect those at-risk areas from damaging loads and give our patients a wider margin of safety. Dr. P.F.D. Naylor performed a series of experiments in the early 1950s. He applied a linear back-and-forth rubbing action to the skin of his human subjects until he caused a blister-type wound. The rubbing was applied with a firm, rubber-like material, and he varied the friction characteristics without changing the rubbing contact pressure. His results were published in 1955. Dr. Naylor concluded, in part, there is an inverse relationship between the friction force and the number of rubs required to form a blister. Let's look at a graphical representation of Dr. Naylor's statement. The vertical axis of the graph represents increasing accumulation of tissue trauma. The horizontal axis represents increasing numbers of rub cycles. That axis could also represent walking time or distance. Naylor's findings simply state that if the friction loads are high, micro damage occurring with each load application will accumulate to a dangerous level in relatively few cycles. If the friction loads are lower, the person may walk farther, sustain more rub cycles, before experiencing a serious level of tissue damage. The graph relates to pain in concert with trauma, but, of course, people with diabetes have diminished protective sensation. They may sustain serious trauma without warning. One can see from the graph that reducing the magnitude of the friction loads would give someone with impaired sensation a wider margin of safe function. In the 55 years since, Dr. Naylor's findings have been affirmed and expanded on many occasions. Dr. Salzberger's group verified Naylor's results with both translational and twisting type experiments. They published their results in 1966. Spence and Shields in 1968 wrote, shearing forces acting on the feet are a primary cause of blisters, callocytes, and trophic ulcers. Salzberger and Akers, writing in Military Medicine in 1972, anticipated what we are teaching today when they wrote, one can also begin to systematically investigate the selection of fabrics and materials in the design of footwear and other gear to reduce friction over the most hazarded points. So that brings us to the practical question. How can we reduce the magnitude of the friction load over those most hazarded points? The equation governing the friction load is the friction force is less than or equal to the perpendicular load. This is the pressure load times something called the coefficient of friction, COF for short. So, the limiting friction load, LFL for short, equation is shown. This is an equation from high school physics. We have known for decades that reducing the pressure, perpendicular, load helps. This equation shows much of the reason why. If we can reduce the perpendicular load enough, the friction load cannot be large. But a big reduction of the load on a bony prominence during all stages of weight bearing is often very difficult. That inspired us to consider the coefficient of friction, the other factor in this equation. Can we do something to reduce the coefficient of friction? The answer is a resounding yes. The coefficient of friction is associated with how easily one specific material surface will slide across another specific material. It is easily measured and may vary greatly depending on the two material surfaces in contact. We have done many of those measurements at Tamarack, and this graph gives some of the results. The graph of our measurements has two bars associated with each of the 5 insole materials tested. One bar is brown and one is blue. The brown bar indicates the COF when the sock and contact surface are dry. The blue bar indicates the COF when there is some moisture present. Some large COF variations are apparent. For instance, the COF for a cotton sock interfacing with plastizote, a popular and effective cushioning material, is about 0.7. The cotton sock interfacing with a polytetrafluoroethylene material at 0.16 is about 75% less. A close inspection of Dr. Naylor's data indicates that even a 50% reduction in peak friction will triple the number of cycles necessary to cause open trauma. Ultra-low friction patch material designed for orthotic, prosthetic, pedorthic use is available, consisting of a PTFE film bonded to a thin fabric. Patches of this low-friction composite may be bonded to insoles, orthoses, prostheses, or other containment surfaces in strategic locations bearing against at-risk areas. We must point out that friction within a shoe, orthosis or prosthesis, is not a problem everywhere. It helps to stabilize the shoe on and under the foot. It aids prosthetic suspension. Friction management is a strategic tool. Reduce friction only in locations where it is excessive. During ambulatory activities, even within perfectly fit shoes and prosthetic sockets, there is always some movement of the bones within the soft tissue. Movement relative to the shoe. Soft tissue nearest the bone translates and twists closely following the bone. But the skin in forceful contact with the sock and insole tends to remain anchored by friction unless and until the limiting friction load is reached. At that point, the skin, and sock usually, will be released to slide part of the way with the bone. If the limiting friction load, LFL, is large, the sock and skin will not be released until the friction reaches a high level, or may not be released at all. If the limiting friction load is low, the sock and skin will be released before the friction shear loads become large. Remember that the limiting friction load can be reduced by relieving the contact pressure or by reducing the coefficient of friction. However, the most effective approach is reducing both pressure and the coefficient of friction. In the short video clip I am about to show you, you will see the first metatarsal head moving within the stationary shoe. The clip quite clearly shows the shear distortion of the skin and soft tissue. Friction between skin and sock and insole keep the plantar skin under the metatarsal anchored. The last half of the clip illustrates what happens when the COF of the sock insole interface is reduced from 0.7 to 0.2. The first part of the video clip shows reference marks being placed on the foot at the first metatarsal head. The sock and shoe have a hole cut in them to allow seeing the resulting distortion on the first metatarsal head area. Note that the shoe fits the foot properly and the foot does not slide inside the shoe. The demonstration begins by showing what happens under the usual conditions in a shoe when the COF between the skin sock and sock insole interfaces is high. Notice that the skin remains stuck in place against the sock and insole material, and the reference lines show the extent of distortion during the loading cycles. The next sequence shows the application of a patch of very low friction material. Now the forces in that area are allowed to release, lowering the friction shear load on the skin in that area. You can observe how the skin slides in that area, greatly diminishing the distortion because of the lowered friction load. Here's a second look at the demonstration. As we noted earlier, we cannot measure or calculate the shearing friction force unless we know there is a sliding at the interface. However, we can graphically reason through to a more precise understanding of why friction management works to protect an at-risk area of the foot. For this example, we look at what happens under the calcaneus between initial contact and foot flat, but the analysis is representative of what happens under any bony areas of the foot. As the heel comes into forceful contact with the shoe insole, it exerts both a compressive and shear displacement stress on the skin and other soft tissue beneath the calcaneus. The black curve on the graph is a qualitative representation of the compressive stress on the soft tissue. If we assume the operative COF under the heel is 0.7, approximately correct for many sock insole combinations, the friction equation allows us to calculate and draw the maximum possible shear stress distribution, red curve. If that area of our patient's foot is showing up as a red hotspot, we know the shear stress applications are exceeding some danger zone threshold, the dotted horizontal line. We don't know at exactly what level to draw that line. We only know for sure it lies somewhere below the peak of the red curve. If we intervene for our patient by lowering the COF of any one of the interfaces under the heel to 0.2, the maximum possible shear stress on the skin under the heel is reduced to the blue curve. The little temporal graph on the lower right illustrates what happens with each heel contact. The maximum possible shear stress peaks are reduced from 0.7 times compression stress to 0.2 times compression stress, a 70% reduction. It seems a very safe assumption that the intervention will be helpful. In spite of Naylor and Sulzberger's experiments, it may still be unclear to many why shear loads are so important. Experimental mechanics experiments reveal that even solid materials like metals tend to fracture along planes of maximum shear stress. Shear superimposed on compression creates dramatic distortion. Repetitions of these distortional stresses will initiate microfractures. If there isn't sufficient time for biological repair, damage accumulates. We have created an animation that may help us appreciate that structural distress. We have emphasized and magnified the basal layer ridges of the epidermis and some vascular elements. The first part of the animation depicts what happens if the skin and sock are stuck by high friction forces to the insole or other contact material. Notice how the skin sock and sock cushion insole interfaces remain firmly in place, and notice the distortion of the anatomical elements as compression and friction shear loading occurs. This animation is an approximation of the distortion in the epidermal layer and below, as was shown in the previous video demonstration. A low-friction interface patch, shown by the very thin blue line, is added to the cushion insole material for the next animation. The second part depicts how the shearing distortion is arrested when the sock and skin are released at a much lower friction level to move in partial concert with the bone. Final still view showing reduced distortion in the contact support area when a lower friction load is present. The compression force is not altered. When friction cycles are light enough or sufficiently interrupted, the biological healing process can keep ahead of damage accumulation. Cell production is stimulated in the basal stratum of epidermis, and callus formation proceeds instead of wound formation. Excessive callus generation is, of course, a very common precursor to the eruption of a foot wound. It is presumed that an unmanaged callus can become so thickened and internally peaked that it eventually wounds the subcutaneous tissue much in the same way as a small stone would. Caregivers report that friction management has significantly reduced and, in some cases, eliminated the need for regular callus thinning. Historically, there have been other approaches to limiting friction shear forces on the foot. Astringents help to keep the skin and sock dry. That is useful because moisture tends to increase the COF of most interfaces. There are socks knit in a way that produces a layer of loose loops under the plantar surface of the sock. That layer of loose loops is able to absorb shear displacement better than ordinary knit socks. There are also socks knit with a percentage of the slippery PTFE fiber. Another popular technique is to don a sheer nylon sheath under the regular sock. The sheath-sock combination creates an additional interface which usually has a somewhat lower COF than the original skin sock or sock insole interface. Friction release then occurs between the sheath and the sock. All of these friction reduction techniques apply to the entire foot, or at least to the whole plantar area. Lubricants such as petroleum jelly, oils, creams and powders, etc. have also been used to overcome friction. Their benefit is usually very short-lived. Lubricants tend to be dispersed and partially absorbed, leaving a counterproductive gummy residue within a rather short time. Powders may also become sticky as they absorb perspiration. We must, at this point, make sure we affirm the value and importance of traditional unloading practices. Perpendicular forces applied to soft tissue under bony prominences give rise to both compressive and shear stresses within the soft tissue. Stress analysis confirms that. What we cannot measure or calculate is what portion of the tissue trauma is caused by compression-induced shear and what portion is caused by friction-induced shear. What we can do is finally address the fact of the experimental findings of Naylor, Sulzberger, and others. In summary, more effective technologies and practices are urgently needed as the incidence of diabetes accelerates and spreads. Our attention has been focused on pressure for decades. We now have the technology available to make a stride toward also unloading friction shear. Just as we approach pressure management by strategically offloading perpendicular forces, it makes sense to reduce friction shear loads on those same vulnerable locations. That is no more or less than paying attention to managing the entire load on what Dr. Sulzberger called the hazarded points. End of lecture number 1. I will be speaking in regards to clinical considerations and decisions for protecting the neuropathic insensate foot. When we look at the diabetic patient who presents with sensory limitations, we are not able to rely on their inherent sensory feedback to determine if their tissue is at risk for breakdown. Through management of direct pressure and shear, we as orthotists and clinicians are able to widen our patient's margin of safety to help encourage chronic wound healing and increase our patient's ability to function for longer periods of time without compromising their skin integrity. As clinicians, we evaluate and obtain impressions for various orthotic devices in a static environment, either non-weight-bearing or partial weight-bearing, and expect our patients to use these devices during dynamic activities. During dynamic activities, the plantar tissue is under considerable perpendicular as well as frictional forces depending on the phase of the gait cycle. First rocker, second rocker, third rocker, single limb support, double limb support. If the orthotic device is conceptualized and fabricated without considering dynamic forces, tissue healing will be difficult to attain. As orthotists and prosthetists, we should consider that many of the devices that we fabricate and fit are being used in dynamic, high-impact, and high-shear environments. While in a static environment, management focuses on direct or perpendicular offloading. Reliefs are created to accommodate the shape of a bony prominence or tissue anomaly. When the individual participates in a dynamic activity, the relief will not be adequate to accommodate frictional forces. In a dynamic environment, the motion pathway should be considered to allow bony prominences or at-risk tissue to glide along a predetermined and pre-modified pathway. The motion pathway may not always be in an elongated shape, as in the case of medial collapse and forefoot abduction. When looking at the development of skin trauma, it is typically repetitive in nature, with the exception of puncture-type wounds. As the skin contacts a surface, an undetermined load is applied to the skin, which results in deformation and elongation. Most skin trauma from orthotic or prosthetic wear is caused by repetitive loading. Problem is exacerbated by poorly modified device or excessive motion within a specific device. Resultant care is to add padding to protect area, grind material to relieve area, or bandage area to absorb drainage. This, in turn, compromises biomechanical principles while altering perpendicular pressure and the magnitude of shear, further exacerbating the problem. There are many variables affecting the outcome of any intervention. Neuropathy, specifically the loss of sensation, creates a very dangerous condition. Information gleaned from the patient history is always helpful when forming a recommendation and plan, and also can be used for patient education. The first case study is a 54-year-old male that has had type 2 diabetes for 25 years. He has been on an insulin pump for the past 2 years. His right foot has a 6-year-old stable midfoot Charcot deformity. For the past 4 years, there has been ulceration problems on the left foot, and osteomyelitis and cellulitis have resulted in resection of the second and third rays. There has been poor compliance with previous management, and transtibial amputation has been posed. Onset of orthotic treatment by this practitioner began 9/18/2009 with the fitting of a custom neuropathic walking boot. Prior to this treatment, the patient has been treated with depth inlay shoes and accommodative arch supports. Healing progressed while using the neuropathic walking boot to the successful closure of the ulcer in February 2010, just under 4 months' time. These images illustrate the fit and design of the orthosis for this patient. There was an inner polyethylene foot support, and pressure and shear unloading of the forefoot was designed. To summarize case study number 1. Original treatment did not result in healing of the forefoot ulcer. The reduced plantar shear and direct pressure during third rocker available in the neuropathic walker facilitated healing in just under 4 months' time. These photos document healing progress while using the neuropathic walking boot. The second case study is a 56-year-old male with poorly controlled type 2 diabetes over the past 13 years. His kidneys are involved, and he has needed dialysis for the past 2 years. He had a grade 3 forefoot ulcer and has been using depth inlay shoes and custom accommodative arch supports for the past 6 years. The first ray was resected due to osteomyelitis and cellulitis. This practitioner began treatment in January of 2010. These images document healing progress while using a custom neuropathic walking boot. Significant healing has occurred in this time period. Special modifications to the cast were necessary because of profuse wound exudate. Dressing variables created a volume problem because of how thick the dressings were sometimes applied. Normal reliefs would not provide adequate clearance in that condition. The modification to the forefoot area is shown to illustrate how much extra space was needed. The lower left image also shows how low friction interface material is employed in the forefoot area. Beige-colored material in the forefoot area. To summarize case study number 2. The ulceration remained unhealed for 6 years with continued ambulation using depth inlay shoes and custom accommodative arch supports. A neuropathic walking boot was provided which relieved compression and shear loading in the forefoot area and was designed to accommodate excessive bandaging. Volume fluctuations in the lower extremity were managed through increasing or decreasing sock ply in the same way as a prosthesis manages volume. These photos document healing occurring while using the custom neuropathic walking boot, as of this writing covering an approximate 4-month time period. Treatment is continuing. The third case study is a 69-year-old male with type 2 diabetes. Multiple ray amputations have been necessary due to diabetic complications. The patient has an extensive 10-year history of using depth inlay shoes and custom accommodative arch supports to address recurrent callus formation and ulceration on the right hind and forefoot. There is also considerable fluctuating edema secondary to vascular insufficiency. This practitioner began caring for this patient in July of 2008. The ulcer healed and the callus area was reduced within 5 months using new depth inlay shoes and custom accommodative arch supports. He remains ulcer and callus free. The shoes the patient originally wore are shown on the top left image. The new depth inlay shoes are fully steel shanked and the fore and hind foot rockered. The blue color patches of low friction interface material can be seen on the custom accommodative arch supports. This patient used depth inlay shoes and custom accommodative arch supports for 10 years, with recurrent ulceration and exuberant callus formation on the right forefoot and hind foot. New shoes were provided, which included a fully shanked and rocked sole. Custom accommodative arch supports were fabricated from same cast as original pair. However, this pair of accommodative arch supports included low-friction interface material in the peak load areas. The patient has remained callus and ulcer-free since December 2008. These photos document plantar surface condition before treatment by this practitioner and through March 2010. Thoughtful consideration of the environment that a device will be used in will allow for effective management of chronic ulceration and callus formation. The motion pathway of tissue and bony prominences during dynamic activities should be considered to increase the margin of safety. This concludes the clinical considerations portion of the presentation. The first 2 presentations in this course discussed the role of friction in repetitive loading skin trauma and clinical considerations for protecting the neuropathic foot from friction. This presentation will focus on the technical aspects of using friction management on the devices you make and fit. Here are some examples of finished applications demonstrating where friction management is accomplished using low-friction interface patches. These images show common problem areas on shoes, such as the posterior lateral calcaneus and Achilles tendon areas. The top left shows an application on the counter and collar of the shoe. The image on the right shows a good way to place low-friction patches when the problem on the foot is both plantar and lateral, such as was the case here on the base of the 5th metatarsal. Through the peak hole cut in the shoe on the lower left image, you can see how a low-friction interface patch is applied to the toe box to protect the dorsum of the foot. Sometimes shoe construction seams cause problems. Sometimes the IP joints of hammer toes rub on the shoe. At the top left, an accommodative insert for a Charcot patient. The prominence in the middle of the foot caused by the Charcot deformity is at risk. In the upper right image, a low-friction interface patch is placed on the accommodative insert in this shoe to reduce the forces on the 1st metatarsal head area. On the lower example, this patient's toes were clawing and the tips were rubbing raw until friction in that area was reduced. The Charcot Restraint Orthotic Walker, also known as crow walkers, crow boots, or walking boots, is an orthosis frequently used for assisting wound healing and as the Charcot patient begins to ambulate. Even though the foot is well located and constrained in a well-fitted crow orthosis, some repetitive loading continues. The skeletal structures continue to move slightly within the soft tissues and relative to the supportive device during ambulation. In this example, friction management is used in a crow walker at the base of the fifth metatarsal and the first metatarsal head to augment pressure offloading and management. The first step to applying a low-friction film patch is to identify the exact location where trauma is occurring on the foot, or where it is predicted. Active wounds, calluses, scars, chafing, and reddening of the skin all point to the trouble spots. Scar tissue, especially when adhered to underlying connective or bony tissue, is very vulnerable. The reduction in skin mobility in that location creates a situation that tolerates virtually no shear stresses before tearing. That means the limiting friction load in this area must be as low as possible because it will be met. Calluses are very hazardous when they become exuberant for people with neuropathic foot conditions. Calluses can act like stones in the shoe, or if they crack open, become portals for infection. The next installation step is to make sure the device is clean and dry. Some new materials have release agents on them from the manufacturing process that impede bonding. Dirt and body oils should be removed when the device has been previously worn. Isopropyl alcohol works well in most cases. The third step is to plan out the coverage area for the low-friction interface patch. If the device is not new, it will be especially easy to see where the effects of rubbing are located. It is also helpful to know the locations of previous problem areas. Locate and size the patch to extend slightly beyond the actual trouble area on the skin. For example, the patch should approximately double the area of a wound or callus. That will position the boundaries of the interface patch outside of the high peak load area. Rounding corners on the interface patch will help prevent it from catching and being pulled back. A scrapbooking die cutter cuts a neat radius on the patch. The fifth step is to work the interface material into place. PTFE film is very thin and bonded to a very thin fabric. The resulting thickness measures 0.02 or 0.51 millimeters. It is flexible and heat moldable, but installing the patch requires some practice technique. As noted earlier, make sure that the surface is clean and dry. It helps to dry run the placement in any application. Then peel the release liner away from the patch to expose the sticky pressure-sensitive adhesive, PSA. Avoid touching the PSA with your fingers and use your best aim as you place the patch into the correct location on the first try. It is possible to pull it off if you haven't set the patch and retry if you need. The heel wrap configuration shown on the upper left shows a flush edge placement. We recommend that the patch be wrapped over any borders or edges to help keep it in place, such as shown on upper right image. Heating the flap helps you stretch it around or over a curved edge or border. Or cutting wing tabs in the material, as shown in the lower images, helps it surround a prominent contour. Covering the plantar and lateral surfaces could be done with one patch, but the solution shown in these two images preserves the ability to remove the insole. Wrapping the patch over the edge of the insole and extending the upper patch beneath the insole border also helps patch adhesion in the shoe. Reaching into deep recesses can be difficult if the shoe does not fully open up. Peel the release liner partially back and hold in your hand so that your fingers help guide placement. The folded over release liner will prevent the patch from sticking to your thumb. Once you tack it into place, pull out the release liner and press the patch firmly into place. The image on the left shows a toe box application through a peek hole. It is a hard-to-reach location, but one that is a relief to the dorsum of the IP joints of hammer toes, or where shoe construction seams create troubles. The lower right image shows long tweezers being used. Tweezers are especially helpful for reaching into deep sockets or any place that you simply cannot get your hands. I would now like to run a short video clip to put these shoe application techniques into motion to improve the demonstration. In shoe demonstration video, the first segment demonstrates a collar application. This is very simple if there is not a significant contour. Wrapping the patch over the edge will help keep it in place. When applying a patch onto collars with increased contours, like these athletic shoes, form wings around the contour prominence as shown here. When there is an area of high friction loading occurring on the plantar and lateral surface, apply a patch to the insole or arch support and then apply a second patch to the lateral part of the shoe. One patch could be used, but then the insole would not be removable. Wrap the patch around the edge of the insole as shown, and apply the lateral patch to orient slightly beneath the insole for a very durable and smooth seam. For difficult-to-reach locations, such as the toe box area, peel the release paper partially back and guide the patch in using your fingers as a guide for placement. Tack into place, then remove the release paper. Press the patch firmly into place. Application onto insoles, especially those configured with very slight contours, is extremely simple. Determine the location and patch size as described earlier, and then it is a matter of peeling and sticking into place like a stamp. Anytime the patch is located on an edge, it is beneficial to wrap it over to help keep the patch in place. For deeper pressure reliefs, some skill is needed to install the patch. The spot heat technique for medium depth contours is our favorite. After designing the coverage area and making sure the surface is clean and dry, place the patch into place, pressing lightly but not setting the perimeter of the patch. Then use a focused heat source to warm the center area of the patch. If you use a heat gun, a small concentrator helps. It is possible to scorch the PTFE film, and the film and fabric components may delaminate if heated too long without being supported. As you heat the PTFE film, it will have a slack look when ready. It does not turn clear or give you other indications of when it is heated sufficiently. Then, rub the patch down firmly into the relief and perimeter areas to set the patch. A soft cloth helps this process. The final result is ready for use. The darting technique works well when the contours are severe. The accommodative insert used in these slides does not have severe enough contouring to warrant using the darting technique, but they show the steps well. Collect excess material as you install the patch and form a tight standing fold. Try to minimize the number of the seams and also form the seams to run parallel with the direction of rub. Small curved scissors work well for trimming a very tight seam. The video following this series will demonstrate a much more complex shape, and it will demonstrate the process better than still images. Inlaying the patch is a secondary operation that maximizes the cosmetic appearance of the patch installation. The first step is to apply the patch with either the spot heat or darting techniques. When inlaying on firm foam, such as No. 2 Plastizote or firmer, it works best to heat the area of the mold where the perimeter of the patch lays. Do not heat to a temperature higher than what the foam manufacturer specifies for the particular foam. In the case of Plastizote, I heat the relief area to 250 degrees Fahrenheit, 121 degrees Celsius. Then, quickly lay the accommodative insert over the mold and apply vacuum. Allow to cool for approximately 5 minutes. If you are using softer foams, such as No. 1 Plastizote, heat the foam and patch area on the device, then place it on the mold and apply vacuum. This is a little quicker because it takes less heat to accomplish the inlaying effect. Here is an alternative way to inlay when you do not have a vacuum press available. Heat the relief area of the mold or the soft insert and then press down evenly by hand. The result is nearly the same as if you used a vacuum press. These close-ups show the difference inlaying can make. The PTFE material is embedded down into the foam and smoothed out during this thermoforming process. The application shown here has a very deep contour. If inlaying is not possible by the methods shown earlier, using a heated tool as an iron is another way to smooth and recess edges down into the foam insole. The tool can be self-heating or heated with a heat gun. Care needs to be taken not to scorch the film or the insole material, and ironing too long may delaminate the layers of the interface patch. Skills doing this are easy to acquire with little practice. The low-friction interface patch will usually last as long as an accommodative insert. In very high friction or gritty conditions, the PTFE film layer can wear away and need to be replaced before the insert is worn out. We recommend you instruct your patients to watch for wear-through. The patient can do this easily when they inspect their shoes and inserts. The white fabric layer will show through as the PTFE wears away. Wear-through does happen, but you can be certain that the foot has been receiving significant protection. Use a heat gun to warm the patch when replacement is necessary. This softens the PSA and allows the patch to be removed. The old patch can then be the pattern for the replacement. When the patch is removed, there may be some residual PSA left on the foam. This should be removed before reapplying the new patch. Use the worn-out patch to blot off any remaining PSA from the device. Warming the residual PSA may be helpful. It is very difficult to remove a well-adhered patch from very soft foams, especially microcellular urethanes, like Poron or PPT, which usually tear. Now I would like to show a video clip of these techniques. As discussed previously, if there are very modest contours, the application is as simple as place and stick. The first segment shows the spot heating technique for applying the low-friction interface material into more complex contours. First, place the patch into place, just tacking down the perimeter of the patch. Using a focused heat source, spot heat the center area of the patch. The material will be ready when it appears slackened. Be careful not to scorch the patch or the surrounding material. Quickly press the material down into the relief area to form the patch. Press the entire patch to set the PSA. For deeper contours, the darting technique works well. Plan out the patch area as usual. Start the application from one end of the relief area, keeping in mind the rub direction. Form tight standing folds in line with this direction. Trim with small curved scissors for a very tight seam. When these applications are completed, they may be used as is. Normal use by the patient, body heat and pressure from weight bearing, will inlay the patch automatically. If the very thin edge of the patch material is a concern and the material it is applied to is foam, the patch can be inlaid into the foam. This segment shows how to inlay using local heat and a vacuum press. Begin by heating the plaster mold, ideally just in the area opposite where the patch is located. Do not heat the plaster higher than the temperature recommended by the foam manufacturer. The temperature can be easily monitored with an IR thermometer. Quickly place the accommodative footbed arch support or insole onto the mold and set the vacuum press. Hold vacuum for at least 5 minutes for the mold to cool, allowing the PSA and patch components to cool. The patch will be smoothed out very nicely and the edges recessed down into the foam material. Using a small iron is another way to inlay the patch into foam. This video shows a heated iron used for making doll clothing, but any heated smooth surface will also work to iron in the material. When using this technique, make sure that you do not overheat the patch material by heating too long or at too high a temperature, as the patch and/or the surrounding foam may scorch, and the patch components may delaminate. Heat and press in only small sections of the patch at a time. On the patch shown in this video, the edge was inlaid in 3 sections. Thank you for your attention. This presentation has been sponsored by Tamarack Habilitation Technologies and Becker Orthopedic. For more information, visit Tamarack online at tamarackhti.com or at Becker at beckerorthopedic.com.